Hello, my name is Gina Green-Harris. I'm the director of the WAI Regional Milwaukee office. On behalf of myself and the WAI Milwaukee team, I want to take time to say thank you. As RAP participants, you have been wonderful to our program and for our program. We have been able to collect data that has been so important for us understanding Alzheimer's disease much better. It has also been data that has been collected that has helped us not only understand Alzheimer's disease, but to build programs to support families who are on the Alzheimer's disease journey. With your ongoing support and volunteerism, we look forward to one day finding a cure for Alzheimer's disease. As I close my thank you, I just want to say, without you, we would not be this far on our educational journey as investigators, as academic staff, as an institution, and as a country. So thank you, thank you, thank you for your contributions to this fight against Alzheimer's disease. May God continue to bless you. Using asset-based community involvement to address health disparities and increase African American participation in Alzheimer's disease research. Experiences from the Wisconsin Alzheimer's Institute Regional Milwaukee office. I'm Gina Green-Harris, Director of the Wisconsin Alzheimer's Institute Regional Milwaukee office. In today's discussion, we will go over information about the RAP study, which is a longitudinal study of preclinical Alzheimer's disease. We will learn about components of the Wisconsin Alzheimer's Institute Regional Milwaukee office, along with asset-based community development and what that model is. We will discuss how we implemented the ABCD approach and we improved community engagement, patient care, knowledge of Alzheimer's disease, and was able to establish social support for African American elders and caregivers. Finally, we'll talk about how this comprehensive model has been effective to increase the representation of African Americans in the RAP study. African Americans are at greater risk for Alzheimer's disease. The prevalence of Alzheimer's disease and other dementias among older African Americans is roughly double than that among non Hispanic whites and is significantly higher than that among Hispanics. Alzheimer's and other dementias are a public health crisis in communities of color in the United States. Alzheimer's disease and other dementias are less likely to be diagnosed or treated. Undiagnosed Alzheimer's disease complicates the management of other comorbid conditions. A majority of care is often provided by unpaid informal caregivers, such as family members. Structural, social, and attitudinal barriers unique to our minority elders and their families further complicate the impact of Alzheimer's disease in Black families. Non-Hispanic Blacks had significantly higher costs of care according to the Care Management Services report, and this was due to high multiple morbid health condition and chronic illness. Despite these health disparities, African Americans continue to be underrepresented in research. Research studies have indicated that African Americans are continuously under-included in many prominent United States Alzheimer's disease biomarker and clinical trials. Also, we know recruitment and retention of African Americans continue to be a challenge because specifically of the cultural and historical barriers that have plagued our communities for several generations. Finally, although not included in this study or these studies, the RAP study itself also had underrepresentation of African Americans in its program. Here are some of the items that have been identified as barriers to research participation: recruitment methods, mistrust, implicit bias, strict investigator participation criteria, protocol that has been developed without including the target population, and the Superman syndrome, which is often demonstrated by researchers. Overview of the RAP study. RAP, a WAI affiliated project, began recruiting in 2001 in Madison, Wisconsin. The mean was 1551, baseline was about 54 years of age, 70% women, 72% had a family history of Alzheimer's disease, and there was an average of 10 years of follow-up at the time when we took this original data. Initial recruitment strategies that were used for the RAP study: we started with diagnostic memory clinics, newspaper ads, and in about 2004, a control group recruitment for RAP was actually targeted towards those who had a UW email address, UW meaning the University of Wisconsin. These recruitment methods inadvertently focused primarily on Caucasians. By late 2005, only 6 of the 711 participants were African American. That's less than 1%, so that was a 0.8%. To address the disparity, Milwaukee added a recruitment site in May 2006. The first recruitment strategy that was tried in Milwaukee included hiring a research program manager that was located inside of a local hospital, hiring an outreach research coordinator but not offering office space or office support, and it lacked strategic recruitment planning that included the Milwaukee community. Over 2 years with this project, the African American enrollment still remained under 2% at the end of 2007. The enrollment increased to 11,063. However, the number of African Americans were still at under 2%. So, as was noted, the strategy that was initially implemented that focused primarily inside of the hospital was changed into developing an asset-based community approach. In this approach, we began to focus our efforts on community engagement, service to the community, advocacy, professional education, and then research. We used the strengths of the university and the community to develop a reciprocal relationship that would then turn into a program that was focused on the needs of the community, the support of the university, and the rebuilding of relationships with families that would then lend itself to not only research, but helping the community cope and understand Alzheimer's disease. So when we talk about building or rebuilding our relationship with the community, one of the first things we had to do was figure out a way to create transparency along with building a new infrastructure of what we have called our liaisons back into the community. And the way we did that was to develop our community advisory board. We used the ABCD model to start our work in an authentic way by talking and addressing the community as experts and building on the strength of the community to say, how have you been resilient without the support of the university? And how can we enhance your resiliency with some of our resources? And what you see here in front of you is that we're showing you that we focus on the strength of the university and the community to build trust, to build ties, and to develop new opportunities for us to grow together. And that is what we were calling community engagement. We moved beyond the idea of outreach to the community, right? Outreach is where you go out, you talk to the community, and you learn what they're doing. Engagement goes that step further to not only learn what the community is doing, but to become part of that fabric work of what the community is doing, and then build off of that for longevity, for future opportunities. We then move from engagement to community involvement, which actually included us asking the community and the CAB in particular to guide our research projects, guide our research in a way that would help us to understand our processes and were they effective in developing strong relationships for engagement, recruitment, and retention. And then we also recognize the community as experts. One of the biggest things we had to relinquish was control as university employees, investigators, academic staff when we stepped out of the walls of the institution into the community. The investigators became the novices and the community became the experts. And that was a really important move for us to make because it allowed for the investigators to learn authentically and in a transformative way from the community. And as a result, we were able to develop a line of commitment from the community. And so, how has all of this work impacted us? At this time, we have over 12 years now of commitment, of research commitment from our community. We also know that our community advisory board is now recognized not only by us as an entity for RAP, but for other research projects and programs. And we also know that we've been instrumental in developing successful research programs across multiple divisions on campus and multiple research programs on campus. And then the Community Advisory Board has been so instrumental in helping us have a UW positive footprint in the Milwaukee, Racine, Kenosha, southeastern Wisconsin areas. And in particular, in African American and other brown communities. So, what else have we done to actually increase our asset-based community development model? When we first came to Milwaukee, we understood that there was the challenge of getting African Americans diagnosed and follow-up care. Um, and so we wanted to back up and not necessarily just focus our efforts on research. Research was critical to what we were doing, but it was not our primary focus. So what we learned was that the African American community was talking and asking us, how can we get diagnosed in our community? We were able to work with Milwaukee Health Services, federally qualified health center located in the heart of Milwaukee, Wisconsin. We were fortunate enough to get funding from the Wisconsin Partnership Program to actually help us develop a diagnostic memory clinic. And what you see on this screen that is represented is we were able to use a model that Madison was actually already using, and that was a triangular kind of care to intervention. And we added another piece to it. But this triangular intervention focused on the patient referral, which you'll see, patient moving into a special memory clinic to get diagnosed. And if you note, there's a physician, a medical assistant, a social worker, all engaged at the same time to discuss the care of the patient, the diagnosis of the patient. Also, the caregiver had a role in this as well. What we were able to do is to add to that triune a community health worker and a worker from our office who was serving in a social support service role, that once someone had diagnostically been tested and or giving a diagnosis of dementia, the care did not stop there. You will notice if you follow the red arrow that we would have follow-up care management services. And these services would be ongoing. It wouldn't stop in the first 90 days. It didn't stop after diagnosis. This care continuum would continue with the health worker, the social worker, and the nurse practitioner from the specific memory clinic. And this was a critical process for us because what this did is it provided the caregiver support and capacity to keep their loved one home longer. We were able to provide education to the person living with a new diagnosis, along with that caretaker of the trajectory of the journey that this person was now experiencing. And the third thing, it provided us as a program opportunities to identify new programs that families would be needing and wanting so that they would have the capacity to care for their loved one with care, with integrity, with knowledge, and with support. That support was so critical to making sure families were able to keep their loved one home safely and for the long haul with longevity. And that's where you see that yellow arrow going down to family support and community engagement. Out of this model, we were able to not only create this memory clinic, but we created dementia wellness programs. We were able to do exercise programs. We were able to partner with Department of Health Services to do access to diet and nutrition programs, all with the hopes of one, helping our person who would develop dementia actually stay home longer, but also to help our caregivers with supportive services. And then the third arm of that was to be able to go upstream and predict who might be at risk and put them in programs for pre-existing conditions. And so we were able to do that. And if you follow that blue curve, you will find that that research was part of our model, but at the very end. And that was important because we did not want to enroll or invite folks to be part of research until after they were stable and their family was stable for the long haul. So how are we doing? Is asset-based community development a good model? Were we effective in our goals? What you're looking at now are some highlights from our research participation of RAP participants. At the time of this slide, originally, we were at 189 people enrolled in the RAP study in the Milwaukee area. Of those, 110 were African American. Today, we're at a total of 227 folks enrolled, and we have 147 African American participants. That makes us at least 11% of the total RAP sample. We believe that using asset-based community development, supporting the community, building new resources, creating a comprehensive relationship with the community that has brought us to be part of the fabric work, not for just research, but as a community resource, has actually increased our research participation. As we conclude this presentation, I want to share a few closing thoughts. African Americans definitely bear a disproportionate burden of Alzheimer's disease and other dementias. We also understand that structural and social barriers affect access to diagnosis, treatment, and family support. Culturally tailored community-based services are needed to reduce inequities and improve access to education, diagnosis, treatment, and prevention programs. Asset-based community engagement programs have the potential to improve quality of care, reduce costs, and decrease burden and improve the quality of life for African American caregivers as well as those who are living with dementia. Finally, use of asset-based models has resulted and can continue to result in increased participation in research of African Americans. Thank you.